Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
I'm Pam Arlotto. Welcome back to the Eye of the Needle, the podcast where we explore the front lines of healthcare innovation, peeling back the layers of hype to uncover what's really transforming care. Today, we're diving into one of the most talked about technologies in healthcare right now, ambient clinical voice. Is it just a better way to handle documentation? Or is it laying the groundwork for a smarter, more connected system of care? To help us separate the signal from the noise, I'm joined by Matt Boyter, a thought leader from KLAS Research, where he tracks emerging technologies and helps healthcare leaders make better decisions about what to adopt and when. Matt will start by walking us through KLAS's latest insights into ambient speech, including what vendors are getting right, where the market is headed, and how health systems are evaluating success. Then we'll open up the conversation to explore how ambient fits into the broader innovation journey. So, Matt, would you do us the favor of introducing yourself and give us a basic definition of ambient speech?
Yes, I'd be happy to. And thank you, Pam, for the opportunity to be here today. So my name is Matt Boyter. I'm with KLAS Research. As Pam indicated, I'm what's called a research director. And oftentimes titles don't really actually define what people do, but I actually get to direct research. So it's very apropos for that. I work primarily around documentation solutions, autonomous coding, CDI, and of course, as you mentioned, ambient documentation. This is something that is a very top of mind topic for different health system teams, both large and small, across different care settings, I might note as well, from home health, post-acute, ambulatory settings, in large inpatient centers. These are all teams looking at ways to ameliorate the friction on clinician burnout, to elevate the physician experience, provide them better, more time back in their day, and provide better patient outcomes in care while also driving down costs. So it kind of has all aspects of those parts of healthcare. This is, again, if you think of the last time you went to your clinician, your doctor, she may have tried to engage with you in conversation. Why are you here today? How can I help you? And then, of course, she would probably promptly turn to a laptop where they would then begin to type away, right? And you're talking to the side of the head of that physician trying to get the information. So ambient technologies are, as the name implies, listening in the background, taking in all the conversation on both sides, even from multi-parties or people speaking in different languages, for example, outside of English, and then providing the ability to take that information using generative AI and put it into a SOAP or a note that can then be cataloged, asynchronously reviewed, and provide that clarity for the physician and for billing purposes, et cetera.
Great, great. And one more quick question before we jump into your overview. For our listeners that aren't really familiar, give us a little background on how generative AI kind of is the power or the engine behind this and what that means.
You bet. One of my favorite things is when someone says we're using AI, and then you actually peel back the layers and turns out it's just a rudimentary version of screen scraping or something else we've had for a decade plus. So true generative AI and these transformer models they're based on LLMs, so large language models, and that's where they become really, really specialty specific. Obviously, the medical ontologies for different groups and different types of practices have to be trained on each of those LLMs. They have to go in there with the correct terminology and jargon and language and those ontologies. And then it basically says, okay, this word is the word that's being used. The next most likely word is this word. And when it's actually training on those languages and those types, it then is able to ingest the unstructured conversational data of just people talking and put it into a way that then says, okay, for the purposes of documentation, here's where it should be slotted. And the true generative AI tools are the ones that can then extrapolate and pull information out of that unstructured conversation to say, this medication type is being prescribed, or this is the order that should be generated, or this is the code that might be reviewed. And that's where we're seeing the next phase. And we'll get into that hopefully a little bit later. Beyond the documentation, what about ENN code uplift or HCC? What about the impact on work RVUs and other things like that? Where is the ROI from some of these tools beyond just decreasing clinician burnout? That's where our research is taking us next.
Oh, that's fascinating. Well, why don't you share your current insights with us?
Love to. All right. So the data that we are showing here is really from our most recent reporting. So over the last year and a half to 2 years, as we all know, the ChatGPT kind of exploded on the scene and has really brought into the public consciousness and the broader consciousness these generative models that have been percolating behind the scenes, really, so to speak, for the last several years. And that's driven this a deeper adoption, this higher level of technology, and especially in healthcare. So the impact of ambient speech, what we're looking at in our research is to find the different ways these technologies are being leveraged today, but also, again, like I mentioned a moment ago, where they are going. So through agentic and generative other engines in AI. Healthcare providers really want to look for solutions that prioritize clinician wellness and benefit, but certainly need to look at the financial aspect and, of course, the patient engagement aspect. I mentioned a moment ago the importance, and as we are all patients ourselves, the importance of that interaction with your physician. Our data shows that patients are actually more apt to pay attention to their care plan, to actually follow through on medications they've been prescribed, and to rate their clinician encounter higher because they are now having a conversation as opposed to being dictated to or getting a note later saying this is what you need to go fill this prescription or this MRI has been diagnosed for or prescribed for this particular reason. So we're seeing a lot of this having these knock-on effects beyond just amelioration of clinician burnout. But clinician burnout is the primary driver of adoption of these tools. Our research shows that amongst cohorts and teams that adopted ambient solutions versus those that did not, within control groups, they saw burnout decrease to the levels from very high levels of burnout to the levels of standardized or the median deviation of burnout. So we've seen improvement as well in after hours workload, where physicians might have been going back in and correcting notes or updating notes or offering asynchronous information. They've seen a significant decrease there in that overall pajama time, as it's known, or out of office or after hours office work. And I also point out that organizations supporting EHR, meaning the EHR satisfaction, the ability for the EHR to be more efficacious, it's actually improving with these ambient tools and technologies as well. We asked a lot of provider health systems, are you planning on offsetting or defraying some of the cost of these solutions by asking physicians to see more patients? And we can tell you that categorically they are not, thankfully. Our data shows that of the systems that do ask or mandate their physicians to see additional patients to kind of offset the cost, again, it makes good sense, right? If you're able to get through more patients in the day, you're
Right.
able to have more of your time back. Why don't we just add 1 or 2 patients to the workload? But what that does is it has an unintended, perhaps unintended, but totally incorrect attitude where suddenly these physicians are seeing, wait, I have more time in my day, so now I'm seeing more patients to offset the cost, and it's actually having a net negative effect on the whole. So
Hmm.
most of the health systems are doing the right thing, in my opinion, which is not justifying the cost by adding more patients simply by seeing that cost differential of not having to replace physicians as often. Our research
Yes.
shows that it's about $1 million, Pam, to replace a typical physician. And that's not a
Wow.
subspecialty, that's like a general practitioner. So,
Yes.
what is the savings if we don't have to replace that physician or they don't retire early or they're not looking to migrate to a different health system? That is a savings right there as well.
Well, and a lot of health systems in recent years, from what I understand, have hired scribes and things like that to help the physicians with all their documentation needs. So I'm sure it impacts that area and allows the physician to do honestly what they used to do in the transcription days, where they just talk through what they had seen, as opposed to having to fill in the templates and do all that click and point and typing. Is that fair?
That's an extremely astute point, Pam, and you're absolutely spot on. And interestingly, we've seen some physicians who became very inculcated to behavior to have that virtual scribe or even at the elbow scribe prior to COVID. But being able to have that scribe, because the scribe did more than just document, they might have assisted with orders, they might have assisted with other things, chart prep before the visit. Now we're seeing these generative AI tools actually do some of those functions as well. So it's not just about documenting the actual encounter in that language. It's also about pulling in prior information, bilateral and data exchange between the EHR so that as the physician's talking with the patient, they can see all the medications they're on. They can pull up all the record from the EHR into the conversation. And then that's the next level about CDS, providing documentation support so that there's this decision support. So now a physician is not being told what to do by the AI. No, not at all. Rather, there are suggestions and different aspects that might be beneficial. And that's something that I think is coming down the pike right now that we're actually starting to see.
Okay.
Adoption is one of the questions I get asked about the most. So we hear a lot about ambient, and like with most new technologies, right, Pam, it may seem hyperbolic in terms of both delivery, adoption. We hear about health systems in the news going live with different solutions, but our data shows that yes, adoption is real, and frankly, for the nascency and the recency of these tools, the adoption rate is much higher than we have
It's
seen with.
it's actually shocking. I mean, because we know we've had new technologies for years and it's taken forever to get people to try them, but this is almost a no never mind. We just have to do it.
You're absolutely right. So there are three main barriers for adoption, typically for health systems. One is the change management, right? Making sure the personnel, the end users, in this case, physicians, which are very busy people, as we all know,
Right.
and have a lot of other things on their plate, getting them to adopt that, go through training. With the second level is IT, right? Your IT support and your team at your health system might have 15 implementations that they're working on. You got to join that queue and eventually it will go live and have that. And then the third is really cost, right? Do we have the budget for this? Can we afford it? Is the value proposition, the ROI really there? With ambient technologies, we see those three issues, those traditional barriers, really not a significant barrier. In other words, there's very little or minimal change management. You open up your iPhone, you turn on the app, you start to speak, and it captures the content. Certainly, there is a lot of post visit, you want to review that note, you want to make sure that everything is complete, you want to ensure that you didn't miss anything. Maybe you need to add a part of the conversation that you didn't want to have in front of the patient, but you want to, for documentation purposes, have be there. But again, in terms of training and education and change management, very minimal. Again, also because we don't have to have, these are cloud-based offerings. They're actually running on servers that are off-site. You don't have on-prem. Therefore, the IT lift is much lower. Again, there's not a lot of change management technology and tools. You're using your existing devices that may be part of the process or your own personal devices if they're properly vetted. And so again, these traditional barriers for adoption, we're not really seeing. And again, the cost, like we talked about, if we can save or retain those existing physicians or attract new talent. One of the interesting things I've had CMIOs tell me is that, yeah, these new doctors coming out of medical school, out of residency, they are looking for a strong work-life balance. They are not willing to work those extra, 2 to 3 hours every day after their visits. They want ambient documentation. They want the ability to have more of their life back. And so there's a balance there.
And they're probably a lot more comfortable with it than other generations would have initially been. I go back to that slide. I do have one
Mhm.
question though for you. So I see that the adoption right now is much stronger in the ambulatory environment.
Mhm.
What's the difference in deploying it in acute care versus ambulatory?
So this is really a question of, and again, it's an excellent question, Pam. Where is the biggest need and the biggest opportunity? And in
Okay.
these cases, that's also being viewed through the lens of, again, I mentioned before how these tools actually work. They have to be built around those large language models have to be trained and built on specific medical ontologies. Well, you have someone who's an interventional neuroradiologist with extraordinarily specific use cases and language. And it's also very candidly a very small subset of the overall
Right.
population of physicians, right? Those patient types. Whereas general practitioners, emergency departments, ED, we have huge volumes of encounters that can be trained and used to train, and they tend to be fairly lower level in terms of those ontologies. So that's where the biggest need is, and also where the easiest or relatively easiest way for these models to be trained on. When we get into other use cases, like for example, orthopedics, or orthopedists love their template system, right? They have a template approach and they really like to go through that process. It's not as efficacious to have that unstructured conversation as you would in like a pediatric or a pulmonologist or something else. So again, the opportunity and benefit really is patient specific, patient type and specialty specific.
Got
So that's
it.
why we're seeing more around the ambulatory space today.
That makes sense. Okay.
Great question. The last thing I'll share here, and this is something maybe for those of your viewers that are kind of considering adopting an ambient solution or are in the process of piloting, some suggestions, if I may. When you look at the cohort of the pilot as you're looking to do that with one of these ambient solutions, the best advice I can give is not to choose volunteers. In other
Mm.
words, don't just look for those who raise their hands and say, I am a technophile, I love this kind of stuff, or I am at high risk of burnout, I am really struggling, and I want a tool that can help me. Why not? Because even though the impact is real, and we have definitely seen that across different groups, get those physicians who maybe are tech averse or maybe who are very comfortable, to your point earlier, with their virtual scribe or other modality for documentation, and have them be participatory in that cohort of that pilot, because in that way you're going to get a really better representation of the impact of these tools across different patient types, across different groups, as opposed to just a very small subset and just volunteers. They tend to be more optimistic and perhaps might alight over some of the shortcomings because they are positive about the technology itself. So that would just be a suggestion. Just make sure that there's a diversity in terms of the representation for that.
Okay.
This chart here kind of shows, again, we talked about this just really briefly. It was an
Okay.
excellent segue, Pam. Great question, great segue. You did great. Where we're seeing the specific adoption within patient types, so family medicine, internal medicine, pediatrics, again, that one surprised me a little bit because if you think about, I have 4 young children, and if you think about a patient encounter there, there's not a lot of bilateral conversation with the patient themselves, right? They may
But
say, my tummy hurts, right? That's
but the
that's the
parent there probably is.
that's
Exactly.
exactly right. The parent or
Right.
caregiver is going to have that conversation. But what's neat about that is that, again, this allows for that unstructured conversation to be structured properly. And these tools can handle different voices, even in different languages. That's something that I think is a social good, to be able to have someone who speaks, Vietnamese or a different language, to be able to have that. And then also to provide back to that patient or caregiver a reductive note written at a reading level that most of us can understand, free from jargon and free from buzzwords and terms, and it with, here's the medication you need to take, when you need to take it, why you need to take it. I want to see you again in this much time, and in their own language. So now we're seeing the impact of healthcare meeting patients where they're at and
Mhm.
providing them and equipping them with the tools so that they can go and have that better outcomes, better experience. So there's some social good there, I think, in terms of the outcomes.
Makes sense.
So there's some other data here, but let me jump down to this, a couple of main findings we found from our recent data, if I may.
Okay.
So some of the things that we get asked by providers, this is what I would like to see, or this is what I would like to have. I don't have this yet, but it's something that I'm certainly looking for. And that is the ability to adapt to documentation style and voice. And when we say voice, we mean the tone
Sure.
of not the audio, obviously, but the way that they speak. Some of the
Right.
very first tools that we looked at, a year and a half to 2 years ago, they were extremely accurate but also
Mhm.
very stilted in the language,
Yes.
right? And
Yes.
a provider, a physician who sends, they're like, I don't want to send this to my patient. It sounds like a robot, because it was very robotic.
Right.
The tools have become much more avuncular, much more colloquial. They're able to share information in a way that sounds like the physician's tone, the way that they would speak to their patients. Providing more functionality is something we still get asked about, though, and that our research shows people are looking for. And then personalization. And I'll talk more about this in a little bit here with another slide. But basically, physicians are looking for more customizable interface. They have their own workflows, they have things that work for them. So being able to meet, and I think that's a function of, and Pam, you can speak to this as well, having seen a lot of technology solutions come into healthcare. How do we meet, again, physicians, these end users, to their needs, as opposed to forcing them into certain, GUIs and work types, be able to meet them where they are.
Sure. Sure. Quick question in this regard. Are they also, or any of these solutions, because we're recognizing how important the patient's voice or the family member's voice is, are any of these solutions also incorporating that information as the conversation goes back and forth between the physician and the patient or the family member? Are they scooping up that information as well?
They are, and they're definitely looking at that. As we look at these tools and how they continue to evolve, it's wonderful to see the rapidity of the feedback, right? So
Mhm.
not just through KLAS, obviously, but through these vendors are doing their own research, but getting that feedback, and they're really adapting rapidly. I think one of the benefits of these types of tools is the flexibility of them, the ability to adapt pretty fast. And because they are cloud-based, they can do it and roll it out immediately, as opposed to
Right.
back in the day,
The
right?
old day. Right.
On-prem. Did you
Right.
update the servers? I don't know. We can only do it at 2:30 in the morning, right?
Yes.
And we
Yes.
want to do it on a Wednesday, and then there's all kinds of hiccups after that. So being able to be more flexible, I think, makes a big difference as well.
Makes sense.
On this area here, this is so two things I wanted to touch on here. And Pam, this is something I'd love to get your thoughts on as well as with your experiential knowledge. So physicians have been the primary point of focus or points of foci for these ambient technologies to date. But now over the last 6 to 8 months and really today, we're seeing the need for and the response to nursing shortages and issues. Every CFO that I've talked to has said, man, the money we're spending for traveling nurses
It's
is
off the charts. Right.
it's off the
Right.
charts,
Right.
and we can't even get nurses, right?
Right.
We can't even find them to hire them, right? Because it's a
Right.
lot of work, long hours. The pay is good, but there's limits on how much the pay can be. And so ultimately, how do we help not just the physicians, but how do we help other caregivers to have a better lifestyle, better work-life balance, etc.? The documentation process for a nurse is obviously very, very different than a general practitioner or ED doc. It's going to be more less conversational and more documentation and other workflow processes. And so that's where the next stage of these tools is really going. And
Yes.
various teams are already building tools in those areas. It's something that we're looking at closely with our research. But it's a hard nut to crack because nurses are all very different as well. Every health system has a lot, even within one health system. ED nurses versus pediatric nurses are doing totally different workflows as well. So I'm optimistic for the process, but it's going to take some time to actually get that there. And then the other big takeaway here is around functionality. So it's great that it does this for me today, but then what have you done for me lately? Is the
Yes.
question that I hear. So what's next, and how is this going to help health professionals? Something interesting that I'm keeping my eye on recently that some of these tools are already developing in coordination with the health systems at their behest is to use vocal intonation, voice patterns, not just from the patient. So there are tools that can actually extrapolate based on patient voice, propensity for Alzheimer's or dementia or depression, things like that, which is really fascinating and interesting. And so it can use the vocal intonation and tone to then find, okay, is this patient at risk of these things? Is that something the physician may need to, address or bring up with them or their caregiver? But also for physicians. So using these tools to capture the tone of voice of the physician for stress levels, are they at risk of burnout? Things like that. It's really fascinating to see some of that, obviously with the physician's full understanding and participation, right? This is not like we're listening and then they're going to call you up and say, hey, it sounds like you're having a bad day, right? You're not going to get that
Right.
from the CMIO. Rather,
Right.
it's about trying to find ways to help improve that physician experience and provide actionable insights back to leadership to be able to make good choices. So interesting things coming down the pike there as well.
Well, and I know there are a lot of neural networks and other types of tools that are being deployed across the entire organization. You can monitor a patient's risk for falls. You can, a lot of where we used to have a person sitting at a monitor, a lot of these tools can do that and warn you need to get in there or somebody needs to do something. And I think what that next level, when you talk about not just documenting or monitoring, but actually acting on a piece of the workflow, the tools will eventually do that as opposed to a person having to do it. We'll be able to, you know, design the process or the workflow and the tools will make it happen, which is very exciting.
It absolutely is. And again, there's a fine line between abdicating the physician or nurse abdicating their responsibility as that primary caregiver to these tools and to AI generally. I think there's a lot of hesitancy
Right.
as these tools go out to the market? Are people making decisions, or is AI now making life and death decisions? The answer is categorically no, and never will be. But I think to your point, can it support some of that decision-making processes? Can they support that and help the physicians and point of care givers?
And the AMA has been very adamant that they view it as augmented intelligence, not artificial, because it will augment the clinician's role, not replace it. And I think that's really very important.
I love that. I love that. And it's an important distinction, especially because of the crowded nature of what even is AI, right?
Yeah.
It's a buzz term that's losing meaning as more things come out there. One of the last things I'll share here on this portion, and then want to segue a little bit into some other things, is again, what is next? So refinement. One of the things that we are hearing a lot about is, okay, that ROI that we've discussed. Okay, great. Our physicians are happy. They're spending less time in note. They are actually getting home earlier to spend time with their families and loved ones. But what is the actual increase in work RVUs? What is the increase in turnover rates, things like that? How do we look at the coding uplift, E&M codes, HCC coding, CDI workflow improvements? So traditional CDI being actually melded into this, because these ambient tools sit at the nexus of that documentation. And as such, they are in a unique position to be able to kind of provide some of those, what have historically been different parts of the downstream workflows and upstream workflows. And it'll be interesting to see kind of where those things go. But again, this is something that we hear from physicians that they're asking for more of that, not less. And
Yeah,
health systems are asking for it.
we're just putting our toe in the water right now. I mean, there's just so much more potential. That's what I'm hearing you say.
Absolutely, yes. That's exactly right. I liken this back to the early days of the internet, which, my oldest is 16 and she's like, what's not the internet? How do we,
Right.
there's no world that she understands without the internet. But those of us who lived through that transition, obviously, we saw think back to the early days of AOL and dial-up modems and what web pages looked like that were just, very, one-dimensional in their development. And what that was then is where we are now with these tools. And so I think the balance though is the hyperbole will take us all the way over the edge. And if you listen to some venture capitalists and other people, it's going to do this panacea. There's going to be all these incomes, possibly at some point, but it's going to be some time. But I also do think I'm an optimist and evangelist in that regard, that I do believe, again, if you go back in time and look at those nascent technologies where they go through that bubble, they go through that cycle, but there is ultimately a transformational change happening, no question. One area here, again, I mentioned about expanding beyond the note. So we've talked a little bit about this. Not much more I want to share here other than, again, billing. Billing and coding impact. That is something that we're just starting to see the impacts of, including prior authorization and its mitigation and impact on denials on the back end. So again, as these tools get more accurate and get more refined and are able to suggest and do more things, then I think we're going to see that real change in terms of how these tools are worked. Now, we recently had an event, KLAS did, where we brought together payers, providers, and different groups. And I may have mentioned this to you, Pam, in our conversations, but we had a chat bot from a payer organization.
Yes, I remember
You know,
this.
talk about this?
Yes.
And then a chatbot AI agent from a provider organization talking about a denial that had been given, and the workflow back and forth between them. And it was actually really amazing to see, because I expected this to be a disaster. I expected this to be a train wreck of, like, circuitous logic, as these
Right.
chatbots just got stuck in a logic loop. And actually it was quite encouraging, because we're using these existing modalities of phone systems
Right.
to have these claims and the conversations, and we're automating with the agentic AI and allowing them to talk to each other. And it went really well until the very end, when one of the bots made a comment about, healthcare is very important. And then the other bot said, yes, it is very important. And then the other one said, yeah, and it's so important. And then it got into that circuitous logic towards the end of the
Well, I
conversation.
was going to ask if they resolved it, or if they ended up in a little bit of a tug of war, like often people would do.
That's the beautiful part about this, is that being divorced from that human
Emotion.
animism, right?
Yes.
Emotion actually led to a pretty solid outcome pretty quickly, trying to resolve the impasse. And so I think there's something to be said for that. Obviously, there's something lost in the nuances of a human being able to kind
Right.
of utilize our true intelligence to be able to do things. But it was interesting.
We often are asked by our clients as we do strategy, whether it's for a health system or for a vendor organization, what is the state of the market? And we usually see with these early technologies, it's kind of the wild, wild west. And there are many, many, many vendors. And then over time, consolidation occurs and there are fewer. And you know the technology's kind of getting more mature, and KLAS picks a few that are doing very well, and the market consolidates. So given that, I would like to ask you approximately how many vendors are you guys tracking in this space? And do you consider it still the Wild Wild West?
Sorry, I love that appellation, Wild Wild West, because that someone else described it to me as being on the floor of a gladiatorial arena
Oh, wow.
and watching these vendors kind of bash each other and bash it out. And that's not entirely fair because these are good actors. These are teams that are looking for market share, like any organization, any business, but they are all, I can tell you, they are very aligned in
Mhm.
terms of truly delivering care. I am constantly encouraged and shocked in a positive way when I speak with the CEOs of these teams and they talk about really improving the patient experience, really moving the needle finally for physicians. Coming as we did out of COVID, where there was a burden on all of these physicians, pulmonologists, and everybody else. And so being able to provide something that finally gives real relief. And as I spoke with some of these physicians specifically, I had one who said, I finally have my life back.
Oh, that's
Uh,
great. That's
she
great.
said, she said, look, I was planning on quitting medicine, not for the lack of joy of medicine, but simply because of the documentation burden was so onerous. I was missing my kids' birthdays. I was missing my family. And now I'm able to have my life back, and it brought the joy of medicine back. So they're real impacts. To your question, there's no doubt in my mind that we are seeing an oscillation
Hmm.
rather than the growth. If you think of it as a two-dimensional view, the growth and a lot of new players come to the market, a lot of startups, they raise a lot of money, and then eventually they kind of get bought up, M&A activity, they go out of business, they can't make a business case, and then eventually we have kind of a bit of a plateau and a drop, and then kind of steadies out. I think in the case of this, if we view it more of an oscillation wave, where we see that growth happening and that expansion wave happening, and then certainly there is a contraction, consolidation, there is movement there, but then we actually are seeing it coming back out again. And what I mean by that is now we have EHRs like Oracle building their own tools. We have
Right.
other eClinical Works and Athena. So we have an expansion wave happening again, kind of within the EHR ecosystem. And I might note in terms of behavioral health, home health, post-acute care, even dentistry, where and that one always makes me laugh a little bit because we've all been to a dentist and they ask that question right as they put something in your mouth and you go, right? That's your response. So how are you ambiently capturing that? Well, they are, right, because they're making those conversations. They're talking about their procedure they're doing and it's being captured, it's being documented for that reason. So but I think that's where we see these contraction and expansion waves happening, and they're not happening within the same segments. They're happening in different areas of the industry generally. So in different areas. Um, so I hope that helps with your question a little
That
bit.
that does. And I guess a question that, you talked about physicians, you talked about nurses. What other roles do you all envision this type of technology helping and supporting over time?
What's interesting is you talk to some of the main EHRs and the main vendor teams, and they talk about a total reinvention of the user interface for the EHR, for example. So instead of
Which
drop-down menus, and
which has been a complaint for a long time.
certainly has, no question. and with cause, right? With cause.
Mhm.
And yet so what's fascinating is that AI really becomes the new UI. It
Okay.
becomes the ability to use voice, not just generative AI tools, but what is traditionally called kind of speech front end tools to use voice to open orders, open this, create this, bring up this information, pull this in. And so being able to do that. So now we have office managers, front end staff that are using voice to actually open different things, to create things, to use in conjunction with and in tandem with generative AI tools to do that. We're also seeing, agentic AI is a big hot topic of different conversations. That's where the next phase is as well, is about how do we interact? And I think this is going to transform the landscape of everything. So
Mhm.
agentic AI is really delivering on the promise of what it was supposed to be with chat bots and decision trees, utilizing AI to actually more effectively help all of us as we navigate. I need to reschedule my appointment, or I have a question for my physician, as opposed to going into a nurse's line that might take, again, pediatric nurse. I have 4 small kids. I've waited as much as an hour and a half to speak with a nurse at a very good practice. But there's so much of a deficiency of nurses, of qualified personnel, and a lot of kids. So there's going to be that queue. Whereas if I can come on and speak with a tool and say, here are the symptoms they're experiencing, they're still having some follow-up issues, and at least have that be the first layer of review to say, okay, don't worry about that fever. This is maybe an issue. Now it's time to bring them back in. Things like that, right? So there's an efficacy there. I think that is the next level.
Well, and you think how much what we do in this industry is repetitive. They see the same patterns, the same um, actions need to be taken over and over and over. And if it can take that routine work and address it so that our clinicians and our other healthcare workforce members can focus on the real critical issues where you need that critical thinking or you need them to look at problems in a new and different way, that'll free them up so much.
Absolutely. If we just think about ChatGPT as an example, there are obviously other incredible tools out there. It has become so ubiquitous in such an incredibly short amount of time.
Yes.
You look at emails, for example, I look at people's emails, and having been very steeped in AI research for quite some time, I can tell based on the use of M dashes, based on the use of some other there's these little indicators, these vestigial tools that you can see, oh, this was generated, by someone, but then they ran it through ChatGPT to clean it up or to provide,
Right.
maybe a structure. And I use those tools myself. But again,
Right.
it's so ubiquitous already, and we're just at the beginning of that process. So I think we're seeing down the lens of a very long telescope, and we're not even close to understanding where we're going totally yet.
So one of the challenges we as an industry had with EHRs, we spent all this time implementing, trying to get adoption, trying to manage change, our old change management processes, et cetera. And so a great deal of resource of money was focused on optimizing the EHRs. And one of my, I guess, points that I noticed during that time is a lot of that optimization work was basically designing the EHR to fit the way we've always worked. But I'm hoping that you'll share with me that these new ambient technologies, as well as some of the others coming down the pike, will allow us to reinvent and change care models, change operating models, change the way we work, as opposed to just optimizing based on the way we've always done it. Is that fair from your perspective?
It absolutely is. And the teams that don't adapt to that new expectation, I think will, like those who do not leverage AI tools. Again, I'm a big fan of the statement that AI doesn't replace people,
Yeah,
but it will replace people who don't use AI.
that's
And
I love that. I agree with you. You're going to have
so
to be able to drive the AI steering wheel, if you will. And it's kind of like here in the Atlanta area, we've gotten Waymo, and I'm always shocked, even though I know what it is and know what it does, to see a car driving down the road with no driver.
I'll tell you, the first time I got in one and drove was quite an experience. Normally, I get in an Uber, and I try to either have a conversation or I might just be on my phone focused on something. I'll tell you, you get into
You-
Waymo, I am watching the road. I am the worst backseat driver in the world going, oh boy, I hope he, of course I shouldn't gender the
no,
non-binary car, but I hope it stops. And of course it does. And then but that's the point is it breeds confidence when we have these systems being deployed, and then it breeds familiarity. Familiarity is supposed to breed contempt. I think in this case, it actually breeds appreciation because it is solving for something that is so overdue. You're absolutely spot on. The EHR as it is today, generally speaking, is not truly transformatively different than it was at its really, launching on the scene back in the day.
right,
And we had the same thing with CAC solutions, right? As
right,
ICD-10 came on the scene, CAC was going to solve for a lot of things and has done great things, but it certainly has never done everything that it was supposed to have really solved for it. We wouldn't need medical coders. It's all going to be basically handled by technology. So this again, I think is where you've got to balance those expectations versus reality, as we all do.
right, right. So I spend a lot of my time helping organizations look at analytics strategies and now moving into AI, what's the difference there, et cetera. And one of the things I'm curious about, do you think Ambient will uncover new sources of data or new ways to make decisions using some of the insights that we may be able to gather with Ambient that we weren't able to do in the past?
It already has. This is a
Oh,
brilliant question, by the way, Pam, and something that I think was not the initial driver of adoption and usage of these technologies. But as we start to ask ourselves, what can we do with this data? So now we have, and again, we need to be conscious about what that actually means. So, for example, that the recording of you talking to your physician, that
right,
is recorded, yes, but it is not being archived in a way that is then liable for privacy violations. Obviously, it has to be HIPAA protected. There's other
sure,
protocols. We don't want people getting access to that data like any other part of the health record.
right.
But that I think is where there is opportunity to, in aggregate, start to look at social determinants of health and start to mine that for other points of data to be able to say, what can we learn from this body of information that we have, and how do we use in a very inception-like way, right? How do we use AI to learn and find those patterns within the content generated by AI? There is a risk to that, of course, like any other technology, but when leveraged appropriately, I think it'd be good. I will say that one of the caveats or cautions that I have heard from some providers, and I think is with merit, is, and this is broadly, you've seen this in some recent news articles if you've been watching some of the, and I won't say anyone in specific, but there are some of these chatbots and tools and that have maybe been in the news recently for some, let's say, less than savory allusions and references to certain historical figures that may not be people we want to be associated with. And I won't get into any detail there, but what AI does is learns from us. It learns on our information. And humans are prone to bias. They are prone to mistakes. They are prone to other issues. And so one of the things we have to be conscientious of is how do we avoid introducing bias into those tools because they're trained on us as humans. An example of this, just in a general sense, is some imaging AI tools that were really trying to highlight and find different ways that they could look for cancers and basal cell carcinomas, etc., melanomas. Well, the problem was it was trained on primarily Caucasian data sets.
Yes, yes,
And
I've
so
heard that.
a person of color with more melanin, it was flagging it differently or completely inaccurately, and it was basically unusable data. So this is an example of where our biases, whether intentional or not, can inadvertently bias the data that's coming out of these generative tools as well. So we need to be mindful of that as we look forward to utilizing these more.
So, what do you think? And so, we've already kind of said we're not going to ask our physicians to see more patients, or most organizations want, but they may have the ability to do different things in the future. Are there any conversations that you're overhearing? Well, now that this physician or these physicians are freed up a little bit, is there any different type of work that they may do that they haven't had the time to do in the past?
It's an interesting question. I don't know that we've had a ton of feedback around that specifically because, again, right now it's been about taking physicians from 10 or 11 down to 6 or 7 in terms of their workload and making things more manageable for them.
And
Now that
upping
we
satisfaction and less burnout.
Correct. And that's been the primary focus. But again, to your point, if we do look at those workflow efficiencies and gains, how can we, while not overburdening physicians, leverage these incredibly dedicated, incredibly smart, very powerful people? I heard this recently as an analogy of, physicians are Top Gun fighter pilots that we reduce to data entry specialists,
Yeah, that's
right?
fair.
These
That's
are incredibly brilliant, dedicated people, and they have been reduced to a very reductive way. So how do we find ways to leverage their skill sets in other their areas or to expand upon that? I think that is something for a good CMIO and good teams to figure out, no question.
so we've talked about the privacy concerns and kind of the overall security of the information. How are executives that are out in health systems today or in physician practices that may not be as familiar with the way the data is protected and the way we ensure privacy and do all the things we've always done with HIPAA, et cetera? How how is their comfort level introducing this level of change into their organizations? What are you seeing out there beyond the CIO or CMIO or others that are familiar with the technology?
The problem is that again, the post-COVID stress level of these physicians and clinicians was so acute. And we had, lots of people leaving the medical field generally. We had levels of burnout that were so high. And so anything that could come in and help with that was a
They were
welcome
ready.
addition. Yes. But now I think we're starting to, as the set faces mature, and to your point, what about the AI regulations? What about most health systems of certain sizes may not have a real governance strategy around AI
Correct.
generally.
You're right.
So they're making these decisions, and it's because of the incipient need, right? That acuity of the need. But now they're starting to say, okay, wait a minute. The federal government's doing different things. State governments, even some municipalities are initiating their own regulations and regulatory impacts. And how do I navigate this? How do I figure this out? How do I make sure that we are on the right side of those regulations and processes? And they're changing on a monthly, weekly basis in some cases. That's a really hard process.
And the other challenge with all these AI driven embedded tool sets in digital health solutions, a lot of these don't talk to each other. And that we're going to have a whole new level of interoperability challenges, I believe,
Oh,
as we get,
absolutely right.
this large language model is different from this one. And how do we kind of make them work hand in glove? I think that's going to be the next level of challenge for many.
Well
Um,
said.
so I'm all about thinking about the next and the next and kind of coming up with a vision and that big audacious goal. What do you think in the when you're just sitting around contemplating what could be? How will ambient maybe be a gateway to broader innovation? Are we going to be able to roll it into virtual care or some of the digital front door solutions or precision medicine strategies that we all talk about? Will ambient play a role in those things?
I think it'll play an integral role. It's going to
Mm,
be, as I said, I think that the AI is the new UI. It's going to reshape our interaction, physician, not just the physician, but again, office teams. We're going to be using it for, it sits again at that nexus of that conversational process with not just the patients, but like I said, it's going to be used for other settings. You mentioned, I think very astute, you talked, Pam, about using generative AI and tools to look for fall risks, right? Using visual cameras to assess someone's risk level there. There's other levels that it can be deployed into. And so I think ambient itself is already reductive to say ambient speech. Ambient AI is probably the better way to describe that, because there
Yes.
really are different parameters and different use cases for what is captured ambiently through audio, video, etc. And then to your point, and I thought this was a really great point, when we talk about the broader implications of all of this data and all of this information, how do we leverage that to deliver better care, to meet patients where they're at, to be more effective with that process? And I think again, that's where you could anticipate a future where you walk into your doctor's office having already received a notification that your appointment is due. This is what's going on, dealing with maybe some billing questions or things like that. But as opposed to filling out the clipboard, opposed to the dreaded clipboard, right?
The more
We're,
saying it on 20 different forms, the same thing, right?
and I already filled it out before I came online, and now I come into the office, I'm being asked to fill it out again. And didn't I just fill this out last time I was here? You already have my insurance info. So that's where I think these tools can be used to say, we're going to use agentic and generative AI tools to be able to get rid of all of that process, decrease the barriers, make sure that we're more effective to bring patients better quality care more appropriately all across the landscape. We are again just scratching the surface of where AI is really going to have those impacts across the spectrum of all those things that you discussed as well, precision medicine, et cetera.
And as you mentioned, it's nascent and we're just putting our toe in the water. But I think the more we put our toe in the water, the more people who might have been a little conservative or risk averse, maybe next time they'll trust it a little bit more, and then they'll do more and more. And that's what I find very exciting about it. It's not like it's a year-long implementation that you have to train everybody and then they forget what you trained them on, and it's so complicated. This is just a common sense, almost a solution in my mind. So I always ask my guest a final question, and I want to know, what is the one thing we haven't talked about today that we should have talked about today from your perspective?
So beyond what we've talked about today, I think predictive models and analytics is probably the next aspect of real transformative change. So using these models, and again, we touched on this a little bit today, but the ability to use these predictive models to extrapolate out best case practices, drugs, new drug creation, et cetera. All of this is the next level. And that's where AI, I think, is really going to help us the most to be able to develop those models based on your previous history, your family history, based on your medication levels, your age, all of these other factors, putting into these predictive models so that we can then really deliver quality of care, bringing in genetic information and markers and information to, again, mold that all together into a model that then says, okay, based on this, this is your diet, this is your follow-up, this is the information you be aware of. And now suddenly we've gone from, this is the holy grail, right? As opposed to there's someone sick, they come in to be seen, we treat that sickness. And we try, and the best physicians try to treat the root cause of those issues, smoking cessation, conversations, whatever that is. But now we're doing something even deeper, further along, where we're really pulling together all these disparate sources of data, genetic markers, information, and we're creating a care plan for that patient that truly has the chance to impact them, even looking at the opportunities of that person's personality, right? Personality types to say, this is someone who's not amenable to changing their diet. They're just not going to do it. So what are some other strategies, solutions we can do to help them mitigate the effects of obesity or other issues, understanding that this is where that patient's at. So meeting patients where they're at, recognizing we are all flawed. How do we meet those patients where they're at and utilize these tools and other predictive analytics to help improve patient care, improve patient
And
lifestyle?
personalize their care plan and make it so unique to them that it actually makes a difference and slows the onset of disease, or possibly they never get that disease. That is so exciting, and glad I'm here to see it, because we've talked about personalized medicine for years, but everybody was kind of like, how are we going to pull that off?
You have so much data from so many different sources. That's what AI does best. It can take all of that unstructured information and synopsize it and crunch it into something usable and delineate it. That's what humans aren't great at. We're really good at really focusing on one thing at a time, and then we go to the next thing and try to kind of put that
Right.
into that process. AI is excellent at taking disparate, unstructured information and putting it together into a
And
structured format
doing it quickly.
and doing it quickly. Absolutely right. That's right.
All right. Well, thank you so much, Mac. I think this is going to be so valuable for our listeners. And I really appreciate your insights and your thoughts. And can't wait to talk to you in about a year and see how things have changed. Because I guarantee you, this area is going to fly. We're just going to see all kinds of new opportunities.
I agree. And thank you so much, Pam, for raising the visibility of this area and for having me on today from KLAS to share some of these insights.
Thanks so much. Have a great day.
Thank you.